I'm a pediatric endocrinologist. I'm working at Mount Sinai in New York City in the division here, primarily as a clinician. So most of what I do is seeing patients. The predominant patient population that I see is a lot of growth and development. And as part of that, my background prior to coming to Mount Sinai is working with pituitary disease. And so in particular, kids born with either congenital or because of postoperative damage, taking care of these kids throughout life in terms of hormone sufficiency. I've been here for about 10 years now. I was down at Johns Hopkins where I did my fellowship, and majority of my time there was actually as a researcher, looking at the growth hormone as well as clinical. But then I'm originally from Northeast here, so I came back to New York. And so part of my work, like I said, is clinical, which includes both outpatient as well as inpatient, because we cover patients within the hospital for various of endocrine disorders. I think it's important for clinicians, and to be honest, I think more importantly for those providers who maybe don't have as much experience with diabetes insipidus. So the other thing is that there's always a sort of a misinterpretation, because most people are referring to diabetes mellitus, which is a completely different condition which deals with insulin. And so as a result, a majority of what we see has to do with abnormality in the AVP, which is the vasopressin, which is the hormone, either deficiency, which we're talking about today, but there are also rare situations sometimes where you might be making, vasopressin, but the patient doesn't respond well, and this is referred to as nephrogenic. So for a lot of the population, when you start to say diabetes insipidus, there's sort of this, again, misconnection with things with blood sugar, and also for parents as well too. And I think, trying to educate them. So I think the name basically helps you target and understand right away exactly what the pathology is. And certainly I think for many of these kids where it can be challenging taking care of them, for any provider, even urgent cares, EDs, I think in many ways it just hones in on what kind of support they need. It's probably been around for a while. I would say, the congenital cases, which are cases where kids are born with it, are certainly much more rare. But nowadays with, I think, increases of technology, in particular, a lot of what we see as pediatric endocrinologists are post-tumor kids. So when there are unfortunately tumors in the brain, sometimes one of the complications or consequences of curing and getting rid of the tumor is damage to the pituitary gland. So that pituitary gland houses many different things: growth, puberty, development, in addition to water control, which is really what diabetes insipidus speaks about. And so it's the ability of the body to retain water and maintain a level of concentration that's appropriate for function throughout. So, some of the development has been, I think, trying to better understand the mechanism in terms of diagnosing these kids, learning what kids are at risk, and then more importantly, treatment, which in most cases is really done obviously with a subspecialist who has experience with it. But because it can be very challenging, and I would say this condition for many respects can be very volatile, which is to say that even with the right treatment, certain environmental factors, whether it's like dehydration or illness, can really, shift the severity of the disease. So, having someone who's knowledgeable, educating parents to be aware, I think is super important in keeping these kids healthy and well controlled. The central core issue with DI, which is basically a deficiency of vasopressin, also known as antidiuretic hormone or ADH, because it focuses on retention of water through the kidneys. The majority of the patients, they initially start with increased urination. And so as a result, assuming there's no other abnormalities in the brain, the body obviously it corrects itself to try to maintain. So as a child is losing water, typically this is accompanied by thirst, so increased thirst, and it causes patients to drink more. And this is a natural phenomenon. We all experience this, and particularly, in the warmer weathers, if we're a little dehydrated or haven't drank in a while, that thirst kicks in. And part of that is coming from the brain to tell you, hey, I need more water in the body. So the challenge is that for a young one, especially even a younger child, is that, sometimes kids are just more thirsty. And no one is sort of keeping heed to it. Sometimes kids have to use the bathroom more often than not. It's particular for the younger kids. Some kids are too busy doing what they're doing, so they'd rather not use the bathroom. And so they start to have accidents, and people, maybe explain it with the fact that they're not paying attention or they're distracted. So the real challenge is that depending on how severe the diabetes insipidus is, because sometimes it can be partial, many patients can often compensate with drinking. And so then they start to get into this cycle, and this cycle of urinating and taking in water. So it takes one, I'm an observant parent. But as they taught me very early in pediatrics when I was training, typically moms and dads are right if they're worried about something. So listening to your parent, and then there are other subtle signs. Obviously, if there's a dysregulation of water control, this can lead to weight changes, poor feeding, and then for kids that are in school, obviously it impacts their school. And sometimes, it can be, I think, a little bit discriminating, right? Because once you have that slightly older child who's otherwise continent and starting to have accidents or accidents overnight, people don't want to talk about it too much. And so you come to understand how, without getting a good history and investigating a little bit more, this can kind of, take a toll. And then once they're in the condition, what happens is that you start to see electrolyte abnormalities. I mean, it's really a condition that you become dehydrated over time. And those in themselves can have, potential complications if not addressed. So when a pediatrician, sees a child and gets this history, quite often, unless you're aware of it, I mean, simple tests like even a urinalysis in the office can sometimes give you clues. A simple blood test looking at electrolyte levels, in particular like sodium, can give you clues. But things are not always so off. So it really takes, a little bit of knowledge and experience to sort of maybe either see that something is off or understand, okay, maybe this is a little more complicated than I need. And quite often, I'll get a lot of times consults, but the truth is that, many of those consults, if it's DI, we probably have lost a little bit of window of time. So, part of what we do as endocrinologists is trying to educate, our pediatricians. And then the other thing I'll just add too is you mentioned about the naming of it, right? So the diagnosis of diabetes mellitus, or typically in kids type 1, starts off with increased urination. And that has to do more with because of high sugars. So quite often, maybe a pediatrician's listening and seeing this, but they don't see any sugar issues. So then they might brush it off a little bit, maybe for something else. But I would say that, often, because the pituitary does so many functions, usually there is something else in the history that might clue you in that this kid might be at risk. So whether it's growth hormone issues, whether it's puberty issues, whether it's trauma, head trauma for some kids. So again, that's ongoing education. And so this is where the challenges are in trying to bring those kids forward so that they can get the appropriate testing to sort of either rule out, or if they have some DI, get them on the appropriate treatment that they need. Well, I think if I'm correct, I think the treatment's been around for quite some time, maybe in the 70s. And so, once we were able to sort of isolate this vasopressin hormone, they were able to manufacture it. And quite cleverly, with a little bit of molecular modulation, they're able to, create a form of the vasopressin that acts like the body, but sort of hangs out a little bit longer. So traditionally, it's been pills that the patients that they take, but in the hospital we have access to IV solutions, which obviously is not practical outpatient, but is very sensitive and controlling if this patient is hospitalized, either in ICU. Then there was developed nasal, so you can do a nasal because the nasal mucosa is very vascularized, so it tends to be a good place for absorbing medication. And then there's also subcutaneous, which basically is an injection under the skin. But, out of all those, treatments, I think the pill form has by far been the most commonly used and sort of acknowledged just because it's very effective. In pediatrics, the difference is that the question is how much. And so right now there's technically only two pill sizes. And so what historically has happened is that, it's a little bit of trial and error. So, what we have to cut the pills in pieces. And I would say for the younger ones, and even as you get into later infancy, it was a matter of creating a certain concentration from dilution and giving it through syringe. So you can see right away that, I think the limitation, even though the medicine is very effectively, the limitation is one, educating the parents on how much to give, learning how much to give with the medication. So that's really just one part of it. I mean, the other part of it is because the medication works well, is really how much to give. And that's where I think the expertise and experience comes in taking care of them, because every kid's different, right? So the way I sort of explain it to parents, if I want to simplify it, it's kind of like having a cup of water, but in DI you have sort of holes in it, right? And so you're losing some of that water. But the extent in terms of how severe that might be, every kid's a little bit different. And what the medication is, which is called DDAVP, it basically helps to slow down that water loss. But every kid's different. And so when we start seeing patients, the importance of it is understanding the child's disease. And what I mean by that is how much are they peeing? How much are they drinking? It's advocating for a certain amount of medication and seeing how they respond, and then balancing the day out with that. So to put it sort of in context, we all have to drink throughout the day. We all have to urinate. That's a normal function. The kids with DI are obviously at risk for, severe or constant, or repetitive urinations, and also drinking. And so you can imagine that really can be a very big disruption to the quality of life. So the challenges is when we give medication is ensuring, are we able to shut down, urination appropriately so they can retain the water they need? Are they able to, say, for example, go to school so they're not asking for water all the time? And then in the home setting, are we able to still allow them to drink appropriately, but we want them to sleep at night, right? So one of the big complaints, especially early on, is that these kids are either waking up to urinate, or a lot of times having accidents. And as you can imagine, in a child who hasn't had those issues before, it's, emotionally stressful, but also disruptive to their overall sleep. So in many situations, it is a lot of groundwork and communication to try to understand the child better, educate the parents, because now you're relying on them to give you the data that you need to sort of decide what's happening. And that's what I'm saying with the medication. The limitation is you don't want to give too much, because if you give too much, then you're retaining too much water. And if you give too little, you're not really doing any service to the family or the child in terms of getting the balance that they need throughout the day. That's a great question, because in particular for the younger kids, quite often, because we're at the mercy of the size of the pills and trying to avoid titrating the medication. And what I mean by that is simply, in many cases, what we would do is we would say dissolve a pill in 5 milliliters or 10 milliliters of water. And then you have that calculation and you tell them how many milliliters to give to get a certain dose. The I think advantage and now the availability of something like Desmoda, which you can actually much more easily titrate the dose, it really helps you to fine tune much better, how these kids take the medication. Now, taking the pill, for most kids, I would say is not too difficult. But you have a solution now, and so that solution, is easy to take, and more precisely how much medication the child is getting. And the one thing if I didn't say, I'll say it again, is that we talked about pills and sprays. The sprays typically are not really appropriate for kids until they're much older, because a spray has one dose. And so quite often the sprays that are available tend to be way more than a child needs. So you're sort of at the mercy right now of only one formulation, which is the pill. So I think for the younger kids, the ability to easily give the medication at different dosing ranges already gives us an advantage. And then the other thing I'll just add in there, if you look at the literature about treatment, the the half-life or the length of time that the medication works typically for DDAVP is somewhere around 6 to maybe 8 hours, depending on the child, and depends on the sensitivity. But if you think about it, the majority of patients are probably getting medications twice a day for the reason that they tend to be pretty well controlled, but also we got to think about quality of life, right? So taking a medication 3 times a day versus say 2 times a day can sometimes be a little bit difficult. And I would argue that, if you have something like a solution that's ready to go that you can titrate, what I foresee as physicians become, more experienced with these newer formulation like Desmoda, you might be able to, in an easier manner, actually really manage their urine output and their drinking a little bit better because giving an extra drop here through the day without having to, take a pill, crush it, and dissolve it, lends itself to be, a little bit easier. So I think that that's really the two big advantages of having something in particular for the little ones because it's so challenging. I mean, I remember taking care of even babies, and what we'd have to do is have the pharmacy literally do serial dilutions of the DDAVP. And as you can imagine, which I didn't mention before, is that even though those work effectively, now what's happening is you're relying on the ability of someone to appropriately dilute that are you sure that you're giving exactly what you want? So a lot of different factors which seem maybe trivial, but at the end of the day, when you're trying to give the best care to patients, you really want to be sure what you're giving, how much you're giving, and whether that's, the right amount for them to stay safe. I think a lot of it is ongoing education about the means in terms of which, diabetes insipidus sort of evolves in a child. I think it's important for pediatricians to understand, for example, that, if you have a child that is either being treated for a pituitary disease or is at risk for pituitary disease, be mindful of the fact that understanding daily activities like urinating and drinking, those conversations are important to have and sort of review because unfortunately with pituitary disease, sometimes things evolve. Sometimes things don't necessarily just present. I think kids with any sort of head trauma, there have been case reports of sometimes, post-trauma kids sort of over time, perhaps maybe not growing or developing well. And to be fair, the major, one of the major roles of any pediatrician and even as an endocrinologist when they get to see me is how are kids growing? So again, if you find to realize that, okay, there's something impacting that area of the brain, then educating, them about what the pathophysiology is. And then with that, I think the how this sort of helps progress is understanding the tools that you use. I mean, the reality is the tools that we use or that outside of the history is a urinalysis. Most general pediatrician's office can do a urine dip and they can see. So sometimes the concentration of the urine in a kid who's urinating a lot can tell you a lot of information. It's not uncommon that some pediatricians might check labs. So looking at electrolytes, if you have abnormal electrolytes, perhaps maybe not chalking it up to the fact maybe they're a little dehydrated. Well, why are they dehydrated? So I think, as time moves forward, continuing to do that education really helps these kids so that they don't necessarily end up in a crisis where they are in the ED. And, I didn't talk about it, but, the complications of, dehydration can be pretty severe from a cardiovascular standpoint, more importantly, from a neurological standpoint. And so, again, even though rare, those are situations, in my opinion, that, really shouldn't be missed if someone is kind of who knows a little bit about the condition, who understands so that they can approach it, appropriately.